clinicians should have very high index of suspicion. And there is a major shift in recent years from in the understanding of the pathophysiological pathway. So I will give an example. I had a patient with intellectual disability and dystonia. Dystonia means he had a raised tone in his lower limbs. So when I evaluated this patient, so his neurological symptom was not fitting into a described phenotype. So then I evaluated that patient and I found that patient was suffering from GM1 gangliosidosis. So that patient presented to me at a 14 years of age, and parents were having no clue that that patient can have an underlying metabolic disorder. So the key was I tried to look for underlying pathophysiological pathway which is affected in this particular patients. So one more point I want to bring here, that if any clinician is finding a patient with multisystemic involvement and that multisystemic involvement is not explainable by common disorders such as sepsis, malignancies, immune immune related disorders, rheumatological disorder, then they should think for a possibility of inherited metabolic disorders. Like few patients present with the eyes involvement in the form of cataract or retinitis pigmentosa, brain involvement in the form of developmental delay, then liver functions, there is a bony abnormality. So then they should think for possibility of underlying inborn error of metabolism. So the point is, if we are getting a patient with multisystemic involvement that doesn't fit into the common disorders, then we should definitely think for inherited metabolic disorders.